I'm Dr. Fakiraveri and this is Bacteremia in adults. The next learning objective is describe the common mechanisms of bacterial resistance to antibiotics. Wild-type bacteria are susceptible to many antibiotics, and they are called wild-type because they have not developed resistance through mutations or acquisition. However, they can still be resistant to some antibiotics intrinsically, and that's what determines the spectrum of activity of antibiotics. Resistant bacteria are the ones that are resistant to antibiotics that normally should have been susceptible to as wild-type. For example, wild-type Staphylococcus aureus is susceptible to penicillin, but you will see that many Staphylococcus aureus strains have developed resistance to penicillin. Wild-type Pseudomonas aeruginosa is intrinsically resistant to penicillin. Now, when bacteria develop resistance, not only can they pass these resistance genes when they divide, but they can also pass it to other species. The transfer of resistant genes occurs generally through 4 different mechanisms. Transformation is when naked DNA transfers from dying bacteria to a competent recipient. Transduction is the packaging of genes, usually from small plasmids, by transducing bacteriophages. One characteristic of bacteria is that in addition to their chromosome, they also have DNA as a circular DNA, which is referred to as plasmid. And this plasmid, because it's small in general compared to chromosome, it can easily be transferred to other bacteria. In conjugation, which is the most efficient way of transferring resistant genes to other species, self-transferable plasmids mediate direct contact by forming a mating bridge between cells. You can see in the picture in the right hand side the different steps of conjugation. Lastly, there can be conjugative transposition. You see, as opposed to chromosomes and plasmids, transposons are specialized sequences of DNA that possess their own recombination enzymes, allowing transposition or hopping from one location to another, independent of the recombinant enzymes of the host. Here are the common mechanisms of antibiotic resistance. Remember, for antibiotics to work, they need to get to the site of action. This provides several opportunities for the bacteria to prevent antibiotics from getting to the site of action. The first mechanism is reduced permeability. In this picture, we're looking at gram-negative bacteria with 2 membranes, so there's the inner and outer membrane. And for many antibiotics to get to the site of action, they need to penetrate through the outer membrane, often by going through a porin channel. So one thing that bacteria can do is to reduce the production of these porin channels, or in some cases even loss of porin production. And that will basically eliminate the channel of entry for antibiotics. There is also something referred to as biofilm, which we will discuss when we talk about bone and joint infections. Now, if the antibiotics manage to go through the outer membrane, some organisms can actually develop efflux pump and pump these antibiotics out. This is a common mechanism in Pseudomonas aeruginosa. Another mechanism is the change in antibiotic targets by mutation. So if the antibiotics do get to the site of action, then the site of action can mutate so that the antibiotic can no longer bind to the site of action. The fourth mechanism is modification of antibiotics itself. So there are beta-lactamases that can actually break down antibiotics. There are also aminoglycoside modifying enzymes that can basically alter aminoglycosides. And lastly, there is alteration of metabolic pathways. For example, the evasion of common pathway to make folic acid, which leads to resistance to trimethoprim sulfamethoxazole. Now, there are other mechanisms of resistance, but these are the common ones that we will focus on. Now, let's compare gram-positive and gram-negative bacteria. So on the left, we can see gram-positive, which only has the inner plasma membrane. There is no outer membrane. So on top of the membrane is the peptidoglycan layer. With gram-negative, there are two layers. So there's the inner and outer membrane, and between the two membranes, there is a small layer of peptidoglycan. Beta-lactams prevent the formation of peptidoglycan. So their site of action is where peptidoglycan is. So in order for the bacteria to make beta-lactamase and break down beta-lactams, they need to be made around the peptidoglycan layer. So you can see that for gram-positives, so this will be actually outside of the cell, whereas for gram-negatives, these beta-lactamases will be basically in the periplasmic space between the two membranes. This basically shows you that with gram-positives, they are likely to lose a lot of these beta-lactamases to the environment because there is nothing to hold all these beta-lactamases as they're being made by the bacteria. Whereas for gram-negative organisms, because of the outer membrane, they can hold on to beta-lactamases. So this is more cost efficient for gram-negative. So you will see that beta-lactamase production is a lot more common in gram-negatives compared to gram-positives. ESBLs are an important mechanism of resistance in gram-negative organisms. But before we can talk about ESBLs, let's consider what is a beta-lactamase. So beta-lactam ring is essentially a 4-member ring, and monobactams only have this 4-member ring, and penicillin, cephalosporins, and carbapenems have 2 rings fused together. And what some bacteria can do is that they can make a protein called beta-lactamase, which can essentially break down the beta-lactam ring, and by opening it, they will make the beta-lactam inactive, and that is a mechanism of resistance for them. And there are a lot of beta-lactamases out there. So there are penicillinases that can break down penicillins in general. And then, later on, when we brought cephalosporins to the market, bacteria learned how to make cephalosporinases, which can break down cephalosporins. And later, when we had carbapenems on the market, they learned how to make carbapenemases. And collectively, these are all referred to as beta-lactamases. And of course, to fight that, we also made beta-lactamase inhibitors. And what beta-lactamase inhibitors are essentially compounds that look like a beta-lactam ring, so that they have affinity for these enzymes that bacteria make. And by binding to the beta-lactamase, the beta-lactamase inhibitors essentially make this inactive, so that these beta-lactamases can no longer inactivate the actual beta-lactam, so the beta-lactam can remain active and kill the bacteria. And we have quite a few of them on the market now. We have clavulanic acid, tazobactam, salbactam, avibactam, weberbactam, and more recently, relibactam. Now, what exactly are ESBLs, or extended spectrum beta-lactamases? So these are the enzymes that can hydrolyze extended spectrum cephalosporins and monobactams. And extended spectrum cephalosporins are essentially 3rd generation cephalosporins, such as ceftriaxone. And they do not hydrolyze cefamycin, so cefamycin are a subset of 2nd generation cephalosporins, and they can also not hydrolyze carbapenems. Now, ESBLs are susceptible to most beta-lactams with the exception of salbactam. So salbactam does not have good activity or affinity against ESBLs. There are different ways to classify beta-lactamases. The easiest one is the Ambler classification that basically classifies them as class A, B, C, and D. Now, from a biochemical perspective, Ambler class B is metallo-beta-lactamase, whereas class A, C, and D have a serine moiety. Class A can be a bit confusing because it has several subclasses. So first we have penicillinases and cephalosporinases, such as TEM1 and SHEV1. And these basically break down penicillins as well as 1st and 2nd generation cephalosporins. These are sometimes referred to as narrow spectrum beta-lactamases. Then we have extended spectrum beta-lactamases, or ESBLs. And these basically are for the most part CTX-M, as well as derivatives of TEM and SHEV. And the reason these are called extended spectrum is that in addition to penicillinases and cephalosporinases that break down penicillins and first and second generation cephalosporins, they also break down third generation cephalosporins, as well as aztreonam. Then we have carbapenemases, which basically for the most part is KPC. And what that means is that in addition to penicillinases and cephalosporinases, these also break down carbapenems. Class B, which is metallo-beta-lactamases, are the worst in class, so they basically break down everything except aztreonam. Then we have class C, which is for the most part the AMP-C enzyme, and these break down cephalosporins and penicillins, as well as imipenem, but they are stable to many fourth generation cephalosporins as well as meropenem. And lastly, we have class D, which are OXA type enzymes, and these are carbapenemases. So in addition to penicillins and cephalosporins, they also break down carbapenems. Now, over the years, we have developed many beta-lactamase inhibitors that can be bundled with beta-lactamases in order to prevent beta-lactamases from breaking down the beta-lactams. So we have clavulanic acid, which can inhibit class A, including ESBL, but not carbapenemases. It can also inhibit class C, but not class B or D. Sulbactam has activity against class A, but not ESBLs or carbapenemases. It is active against class C, but not class B or D. Tazobactam is active against class A as well as ESBL, but not carbapenemases, and not class B or D. It is active against class C. Avibactam, which is a broad spectrum beta-lactamase inhibitor, is active against all class A, including ESBL and carbapenemases. It is active against class C as well as class D, which is OXA48 type. But it is not active against class B. Weberbactam is active against all of class A and C, but not class B or D. And Relibactam is active against all class A and C, but not class B or D. Now, in addition to their inhibition of beta-lactamases, some of them also have activity on their own against some organisms. Now, the one that's clinically important is that sulbactam itself is active against Acinetobacter. So this is something that clinically is used. So regardless of what sulbactam is bundled with, in the United States it's bundled with ampicillin. So we have ampicillin sulbactam. So the sulbactam component, but not ampicillin, has direct activity against Acinetobacter and is sometimes used clinically. That was a lot of information, so let's summarize. In general, beta-lactamases can be broken into serine beta-lactamases and metallo-beta-lactamases, and the Amler classification can be used to classify these beta-lactamases. So class A can be divided into narrow spectrum, ESBL, and carbapenemases. Narrow spectrum includes TEM1 and SHEV1, among others. And fortunately, we have many beta-lactamase inhibitors on the market that can inhibit these beta-lactamases. Now, in addition, there are also ESBLs under class A, and these are CTX-M for the most part, but there are also some derivatives of TEM1 and SHEV1 which have over time mutated, so we call these TEM type and SHEV type. There are many different ones of these. And these are extended spectrum because they can break down third generation cephalosporins as well as monobactams. Now these are pretty much inhibited by most of the beta-lactamase inhibitors on the market except sulbactam. Now the worst type of Amler class A are the carbapenemases, including KPCs, one of the most common ones. And there are a select few beta-lactamase inhibitors that can block KPC. Now, just because these are called carbapenemases doesn't mean that they cannot break down penicillins or cephalosporins. They do. Now, Amler class C, for the most part, it's cephalosporinases, AMP-C, and they do break down one carbapenem, imipenem, but they cannot break down meropenem or doripenem. And fortunately, many of these beta-lactamase inhibitors can actually inhibit AMC. And the worst type of class serine beta-lactamases are class D. These are carbapenemases as well. And the most common one, or perhaps most clinically relevant one, would be OXA48. And the reason this one is important is that this is the only one that's inhibited by avibactam. Anything else in class D is not inhibited by the beta-lactamase inhibitors on the market. And then overall, the worst type of beta-lactamases are the metallo-beta-lactamases. These are under AMBER class B, and these are also carbapenemases. So IMP, NDM, and WIM are common examples. And unfortunately, we don't have any beta-lactamase inhibitors on the market that can inhibit this. Let's take a look at Staphylococcus aureus. So Staphylococcus aureus can be divided based on its pattern of resistance. So the viral type, which is basically penicillin susceptible, is constituting less than 10% of the isolates nowadays. Then we have MSSA, which is methicillin susceptible. MSSA is resistant to penicillin. Then we have methicillin resistant, so MRSA, and the drug of choice for MRSA is vancomycin. Now, while very rare in the United States, there is also vancomycin intermediate Staphylococcus aureus, or VISA, and that is basically that Staph aureus is no longer susceptible to vancomycin, but the MICs happen to be in the intermediate range. And then we have Staphylococcus aureus with MICs in the resistant range for vancomycin, which is referred to as VRSA. Now, MRSA is clinically important, and in general, there are different types of it. So we have healthcare associated MRSA, and then we have community associated MRSA. Now there's also livestock associated MRSA based on the antibiotics that are used in animals and in food production. But clinically we basically break these down into healthcare associated MRSA or community associated MRSA. And healthcare associated is the more common strain which most healthcare professionals encounter, and this strain is resistant to beta-lactams with the exception of ceftaroline and several other classes, making prefer therapy more broad spectrum agents. Now, community acquired MRSA is strain only found in the community, and other classes other than beta-lactams are still possibly active against these, so such as like doxycycline, moxifloxacin, trimethoprim sulfamethoxazole. Now, something of note is that the resistance genes that make Staphylococcus aureus resistant to methicillin is the MECA gene, which can be identified on rapid diagnostics, and this is the gene responsible for alterations in penicillin binding protein 2A, and that is the target site for methicillin class, so nafcillin and oxacillin, as well as cefazolin, they bind to the site. So when there is mutation, alteration in this, they no longer can bind to penicillin binding 2A, which makes it resistant to that class. Enterococcus species, which are gram-positive, can develop resistance to aminoglycoside in 25 to 50% of the isolates. And these are basically plasmid-mediated resistance that are aminoglycoside modifying enzymes. And of course, there is vancomycin-resistant enterococcus, or VRE, and there are two main genes that make VRE, so VAN-A and VAN-B, both of which can be identified with rapid diagnostic tests. And basically, the site of action for vancomycin is the alanine D-alanine, and what happens in enterococcus with these genes is that basically it mutates and changes the second alanine to a lactate, and as a result, vancomycin can no longer bind to the alanyl D-lactate, and this mutation basically does not interrupt the life cycle of enterococcus. So enterococcus at this point will be VRE, it continues to replicate, and vancomycin will be ineffective. Now, enterococcus is part of the human flora, so it is common for people to be colonized with VRE, and that's something that can be detected by screening tools on the stool sample. Lastly, let's take a look at E. coli. So E. coli is a gram-negative rod, and it can be resistant to many antibiotics, so including resistant to beta-lactams, and it's primarily through various beta-lactamase production. So including some strains can be ESBL producing, as well as KPC, which is a carbapenemase, as well as OXA48, which is a carbapenemase, and of course the whole subclass of metallo-beta-lactamases that are carbapenemases. So E. coli can be very resistant. At the same time, a wild type E. coli can be pan-sensitive to many antibiotics. Now, trimethoprim sulfamethoxazole resistance is basically increasing, and it is due to overproduction of dihydrofolate reductase. So dihydrofolate reductase is the site of action for trimethoprim, as well as mutations in the gene DHPS is the site of action for sulfonamide, so sulfamethoxazole. Fluoroquinolone resistance can be due to polymorphisms in the GIR-A, which is a gyrase, the gene for the gyrase, and basically that's the site of action for fluoroquinolones such as ciprofloxacin. Tetracycline resistance can be due to expression of efflux pumps, which is encoded by the... We described the common mechanisms of bacterial resistance to antibiotics. Now let's explain the mechanism of action and spectrum of activity of beta-lactam antibiotics. There are 4 classes of beta-lactams. There are penicillins, cephalosporins, carbapenems, and monobactams. And they are all bactericidal. What bactericidal means is that they actually kill the bacteria very fast. So as time goes forward, the number of colonies actually drop very quickly, as opposed to bacteriostatic agents that don't necessarily drop the number of colonies but actually halt the growth of bacteria, so the number of colonies actually stay the same over time. Beta-lactams bind to penicillin binding proteins, or PBP, and there are different types of penicillin binding proteins which result in different spectrum of activity of beta-lactam antibiotics. Now, the first beta-lactams are penicillins, so these enzymes were named after the first beta-lactams, so they are called penicillin binding protein, but they are also known as transpeptidase. And transpeptidase is an important part of cell wall synthesis. So by inhibiting penicillin binding protein or transpeptidase, beta-lactams inhibit cell wall synthesis. Now, without going into too much detail, the synthesis of peptidoglycan involves several steps, and one crucial step is the cross-linking of components of peptidoglycan, and that cross-linking is done by transpeptidase enzymes, and that is the site of action of beta-lactams. Let's take a look at the spectrum of activity of penicillins and monobactams first. So when it comes to penicillins, these are they're essentially subclasses of penicillins. So the first penicillins to come to the markets were actually called penicillin, and we have 2 different forms, penicillin G and penicillin V, with identical activity. And these have good activity against beta hemolytic strep, but they may not have the best activity against Streptococcus pneumoniae. Now, they are active against most E. faecalis, but they have no activity against Enterococcus faecium, and they are not active against any Staphylococcus aureus. So MSSA and MRSA are not active. There is a small subset of Staphylococcus aureus called penicillin susceptible Staph aureus that these agents are active against, but those are essentially less than 10% of all Staphylococcus aureus. And the reason is that majority of Staphylococcus aureus actually produce penicillinases that break down penicillin, so they don't have activity against MSSA or MRSA. And they don't have any activity against gram-negatives, as well as anaerobes or atypical organisms. Now, the next set of penicillins are referred to as anti-staphylococcal penicillins. So these are nafcillin, oxacillin, dicloxacillin. So these are colored the same just to help you navigate this chart. So the 3 have identical spectrum of activity. Now, they are called anti-staphylococcal penicillins because they have activity against MSSA, However, they are not active against MRSA. In fact, none of the penicillins are active against MRSA. Now, when these became stable against MSSA, it came at the cost of losing some of the activity, including they lost activity against E. faecalis, and they had generally poor activity against beta hemolytic strep and strep pneumo. Now, the next set is aminopenicillin. So this is ampicillin and amoxicillin, which have identical spectrum of coverage. Ampicillin and amoxicillin, they do have improved gram-negative activity compared to the previous subclasses of penicillin. So they get some activity against H. flu and including E. coli, Klebsiella, and protease. But it comes at a cost because they lost activity against MSSA because they are no longer active or stable against penicillinases that Staph aureus makes. Now, they do have activity against beta hemolytic strep and E. faecalis and somewhat against strep pneumo. Now, by adding beta-lactamase inhibitors to these two, so now if you combine ampicillin to sulbactam and amoxicillin with clavulanate, you gain some of these activity. So now the penicillinases from Staphylococcus aureus are neutralized by these beta-lactamase inhibitors. So ampicillin, sulbactam, and amoxicillin clavulanate are active against MSSA, and they do gain better activity for gram-negative organisms. And more importantly, they also gain activity against Bacteroides, which are anaerobic organisms. Okay, so Bacteroides also make penicillinases that pretty much kill majority of penicillins, but the ones that have beta-lactamase inhibitor, including piperacillin tazobactam, they gain activity against Bacteroides. Now, Bacteroides become very important when we talk about intra-abdominal infections. Now, the last and the broadest penicillin is piperacillin tazobactam, so excellent activity against beta hemolytic strep, against strep pneumo, as well as E. faecalis, but not against E. faecium. It does have activity against MSSA, but not MRSA, and pretty good gram-negative coverage overall. But more importantly, this is the only the only penicillin that has activity against Pseudomonas aeruginosa. Now, the only monobactam on the market is Aztreonam, and it's important to note that Aztreonam does not have activity against any gram-positive organism, so it's all red for gram-positives. Now, it does have some good activity for some of the gram-negatives, including H. flu, as well as some of the Enterobacterialis. However, it does have somewhat poor activity against Pseudomonas. So over time, activity of Aztreonam over Pseudomonas has decreased. And moreover, it doesn't have activity against Bacteroides or atypicals. Now, let's take a look at cephalosporins. We have a lot of cephalosporins on the market. These are select few that are more commonly encountered, but there are a lot more. And cephalosporins in general are thought of in generations. So there is first generation, second generation, third generation, and fourth generation. And then at some point, we kind of stopped calling generations because it started to be inconsistent. Now, in general, you go from low, narrow spectrum to broad spectrum as you go higher with the generations. So we have for the first generation, cefazolin and cephalexin. They have essentially identical spectrum of coverage, so good activity against beta hemolytic, somewhat activity against strep pneumo, and nothing against Enterococcus species. And they do have activity against MSSA, so even though Staphylococcus aureus makes penicillinases, it cannot break down cephalosporin, so this is active, but they do not have activity against MRSA. In fact, ceftaroline is the only beta-lactam in general that has activity against MRSA in the US among the agents that are available in the US. There are other beta-lactams that are available elsewhere that may have activity against MRSA. Now, for gram-negative, First generation, they have somewhat activity against E. coli, Klebsiella, and protease, but you typically need susceptibility results to confirm, and they don't have activity against Pseudomonas, Bacteroides, or atypicals. Now, when we go to second generation, again, it's important to note that there is a subset of second generation referred to as cephamycin, so that's cefoxitin and cefotetan. And the rest of second generations, one example is cefuroxime. Cefuroxime has good activity against beta hemolytic, but not strep pneumo. And again, all of them are good with MSSA. When it comes to gram-negative, cephamycins have improved activity against gram-negatives, especially some of the Enterobacterialis. And cephamycins also have activity against Bacteroides, so that's unique. When you look at cephalosporins, none of them have activity against Bacteroides except for the two cephamycins that we have. Now, third generation cephalosporins, you will see we have the first three are oral, and then we have the IV formulations. So in general, somewhat good activity against gram-positive organisms. And then when you go to gram-negatives, in general, they have pretty good activity against gram-negative organisms, but they are not active against Pseudomonas except ceftazidime. So ceftazidime is the only member of the third generation cephalosporins which has activity against Pseudomonas aeruginosa, and it has a very good activity, ceftazidime. When it comes to fourth generation, cefepime is the only fourth generation we have, and the unique thing about it is against Pseudomonas, excellent Pseudomonas activity, and it also has good gram-positive activity, so beta hemolytic, strep pneumo, and MSSA. And ceftaroline, which some people would call it fifth generation, and others would call it anti-MRSA cephalosporin, because it's the only cephalosporin in the US with MRSA activity, and it's also has activity against Eficalis, and good activity against gram negatives, but the only hole in it when it comes to gram negatives is that it does not cover Pseudomonas. So that's one shortcoming of ceftaroline. And more recently, we had cefiderocol come to the market, and just like aztreonam, cefiderocol does not have activity against any gram-positive, but it has perhaps the best activity against gram-negative. So it pretty much covers anything that's gram-negative that's clinically important, including Pseudomonas and Acinetobacter. Pretty much majority of these beta-lactams are not good against Acinetobacter. Cefiderocol has good activity. So cefiderocol is a novel siderophore cephalosporin. It is still considered a beta-lactam, but so it does bind to penicillin-binding protein, but it's somewhat unique because the way that it enters the cell is that it hijacks the siderophore that comes with the bacteria. So what the siderophores do, they're actually natural iron chelating molecules that are released by bacteria to facilitate the transport of iron into cell for survival. So, bacteria do need iron to go into their cell. And what cefiderocol does is that it hijacks, so it's kind of like a Trojan horse, and it hijacks the system to find entry into get entry across the outer membrane so that it can bind to penicillin binding protein. And this is, kind of neat because it can overcome some of the mechanisms of resistance in gram-negative. So because it doesn't depend on porin channels to enter outer membrane, it doesn't matter if the bacteria make changes in porin channels. And it's also somewhat stable to efflux pumps. So, that's the reason for its excellent activity against many gram-negative organisms. And to make it even better, its structure is stable against hydrolysis by many beta-lactamases, including metallo-beta-lactamases. So remember, when it comes to metallo-beta-lactamases, these are amyler class B. They pretty much break down all of the beta-lactams, and none of our beta-lactamase inhibitors can block these. Now, cefiderocol is actually stable against metallo-beta-lactamases, meaning metallo-beta-lactamases cannot break down cefiderocol. So here's a figure that it shows you how cefiderocol goes across the outer membrane into the periplasm space where it can bind to penicillin binding protein. So essentially it hijacks the system where the bacteria is trying to bring iron in, and cefiderocol hijacks the system and goes in and finds penicillin binding protein. Now let's take a look at the spectrum of activity of carbapenems and cephalosporins. So essentially we have ertapenem, which has a narrower spectrum of activity compared to other carbapenems, and the reason is ertapenem does not have activity against Pseudomonas, so it's somewhat narrower compared to the rest of them. Now all of them are active against Bacteroides, and all of them are active against MSSA, but none of them are active against MRSA. Imipenem has really good activity against pretty much most of the clinically important organisms, including Pseudomonas. It's also active against E. faecalis. With meropenem and doripenem, pretty much identical to imipenem with the exception of E. faecalis. They are not active against E. faecalis. Now more recently, we have added beta-lactamase inhibitors to meropenem and imipenem to overcome some of the carbapenemases that are made by Enterobacterialis. So you will see that the spectrum of activity in this table looks the same, but essentially the advantage of these two is that things like E. coli and Klebsiella, if they happen to make carbapenemases, then meropenem and imipenem will no longer be active, and these can potentially overcome those mechanisms of resistance. And in the case of imipenem, because imipenem alone is not stable to AMP-C, if there happens to be an organism such as Pseudomonas that makes AMP-C, then really Bactam can block AMP-C so that imipenem will continue to have activity. So when you compare meropenem, Weber Bactam, and imipenem, really Bactam, the role of imipenem, really Bactam would be that extra activity against Pseudomonas. Otherwise, they both have good activity against carbapenem-resistant Enterobacterialis. And lastly, we have cephalosporin combinations with some beta-lactamase inhibitor. So we have ceftolozane tazobactam. So ceftolozane is kind of similar to cefepime, but it's not available alone, so it was not listed in the previous table. It's only available in combination with tazobactam. So in general, not much activity for gram-positives, but it has good activity against gram-negatives, particularly for Pseudomonas. So the reason they developed ceftolozane tazobactam was really to target Pseudomonas that were potentially resistant to other available agents. So if you have Pseudomonas resistant to cefepime and piperacillin tazobactam, or even resistant to carbapenems, if you have Pseudomonas resistant to meropenem, ceftolozane tazobactam could potentially still have activity, so very potent against Pseudomonas. And of course, ceftazidime alone was active against Pseudomonas, and in combination with avibactam, it really has become a potent agent against carbapenem-resistant Enterobacterialis, so CRE. So some of those E. coli and Klebsiella that make carbapenemases, ceftazidime avibactam could potentially be active against those. So and ceftazidime avibactam came to the market before we had meropenem, Weber Bactam, and imipenem, relibactam. So it really had a big role in when we had Enterobacterialis that were resistant to carbapenems. Ceftazidime avibactam would have been the only drug of choice at the time, but nowadays we have these carbapenem combinations with beta-lactamase inhibitors, so we have several options now for carbapenem-resistant Enterobacterialis. Now, daptomycin, let's talk about the mechanism of action of daptomycin. Its class is cyclic lipopeptide, it binds to bacterial membrane in a calcium-dependent manner, followed by the oligomerization of antibiotic molecules within the cell membrane, which results in depolarization, loss of membrane potential, and cell death. So that's the mechanism of action. And when it comes to resistance, it's more likely to be encountered in enterococci than staphylococci. So, for the most part, MRSA is susceptible to daptomycin. It's really hard to find MRSA that would be non-susceptible to daptomycin. It's more common to find enterococci that might be non-susceptible to daptomycin. Now, something cool about daptomycin is the seesaw effect, which essentially means that as daptomycin MICs go up, in either staphylococci or enterococci, we can see that beta-lactam MIC go down. So it's kind of seesaw. As the MIC of one goes up, the other one goes down. And the mechanism of this effect is not clear, but this has some important roles because if there are situations where we are concerned about resistant develop, we could potentially combine beta-lactams and daptomycin, and the combination would be very effective, because if the organisms develops resistant to one, then it becomes more susceptible to the other one, and vice versa. So it's kind of like a seesaw. And this is not just unique to daptomycin, the same effect also applies to vancomycin. So if you were to combine vancomycin with a beta-lactam, there would be a seesaw effect expected, specifically for staphylococci and enterococci. So here's the spectrum of activity of daptomycin. Excellent activity for gram-positives across the board, and absolutely no activity against gram-negative organisms. So this is an antibiotic directed at gram-positives, including MRSA. So excellent activity against MRSA and all sorts of enterococcus, including VRE. So when we have vancomycin-resistant enterococcus, daptomycin would be one of the drugs that would have excellent activity. We described the common mechanisms of bacterial resistance to antibiotics and explained the mechanism of action and spectrum of activity of beta-lactams. Now, given a patient case, recommend effective drug therapy for the treatment of bacteremia. Now, blood is a sterile site. There is no such thing as colonization of the blood. So any organism in the blood is referred to as bloodstream infection. Now, bacteremia specifically means presence of bacteria in the blood, whereas fungemia means the presence of fungi in the blood, and viremia means presence of viruses in the blood. Because there are different types of fungi, and candida are the most common type of fungi, there is also candidemia, which refers to the presence of candida species in the blood. Now, because blood is a sterile site, bacteremia is always the result of translocation of bacteria from somewhere else. So it's important to identify where the bacteria is coming from in the blood. This could include seeding of organism to a foreign object, such as intravascular catheter, as well as prosthetic devices. Infective endocarditis is a common source of bacteremia, and it is referred to an infection of the cardiac endothelium and can present as either acute or subacute disease. So when a patient has bacteremia and the source of the bacteremia is not clear, infective endocarditis must always be investigated, especially for gram-positive bacteria. Now, when should bacteremia be suspected? There is something referred to as the SIRS criteria, or the Systemic Inflammatory Response Syndrome. And that includes 4 criteria, and if the patient has at least 2 of these, bacteremia should be suspected. So that includes a fever, which is defined as a temperature of 38 degrees centigrade or 100.4 degrees Fahrenheit, or hypothermia if someone temperature is less than 36 degrees, as well as heart rate over 90 beats per minute, respiratory rate over 20, or PaCO2 less than 32. And lastly, white blood cell more than 12 or white blood cell less than 4. So the first one is leukocytosis, the second one is leukopenia. Alternatively, if the bands or segs are more than 10%, so these are the premature neutrophils. Bacteremia should also be suspected if a patient has sepsis, which will be discussed later in the course, or if the patient has hypotension or shock, presence of indwelling catheter. Other non-specific factors include inflammatory markers such as C-reactive protein, ESR, or procalcitonin. Now remember, not all fevers are due to infection. So possible origins of fever include infection, malignancies, autoimmune conditions, deep vein thrombosis, or even drug-induced fever. So drugs such as anticonvulsants, beta-lactams, minocycline, allopurinol, heparin, captopril, nifedipine, and ibuprofen can also cause occasionally a fever. And of course, there could be a fever of unknown origin. Now, once bacteremia is suspected and blood cultures are ordered, when the results of blood cultures are positive, the question is the blood culture contaminated? This typically happens because organisms that live on the skin can enter into the sample. So common contaminants of blood culture include coagulase-negative Staphylococcus aureus, Bacillus species, Macrococcus, Corynebacterium, and Cutibacterium. Now these are some of the organisms that exist in the environment that can find their ways on the skin and sometimes into the sample. So it is important to get multiple blood samples from separate venipunctures in order to see if the organisms grow in all cultures. So if only one of the samples is growing one of these contaminants, it's safe to assume that it's a contaminant. Whereas if multiple cultures are growing, for example, coag-negative staph, it's less likely to be a contaminant and it's more likely to be a true infection. Now, these organisms should never be ruled out as a contaminant. So Staphylococcus aureus, Streptococcus pneumoniae, group A strep, gram-negative bacteria, Bacteroides, and Candida. So even if one of several cultures is growing Staphylococcus aureus, for example, it should be treated as an infection because these organisms, they kill patients, so therefore they should not be taken lightly. With viridin streptococci and enterococci, because they can be through pathogen or contaminant, they should really be judged based on the clinical presentation and severity of infection of the patients. Now, it is important to get blood cultures before antibiotics are started if possible, in order to increase the yield of the blood cultures. It is important to have source identification, for example, for catheter-related bloodstream infections. Symptoms are always helpful to identify the source of the bacteremia. For example, pain, depending on what region of the body the pain is coming from, can be a clue to where the bacteria found their way into the blood. Inflammation of a certain location can be helpful. Microbiological cultures of the site. So for example, if somebody has a UTI, so if the urine culture is growing the same thing as in the blood, it could be the source. Or if someone has pneumonia and a respiratory sputum culture is growing the same organism as the blood, that could be the source of bacteremia. As well as imaging. So if no organism is identified in other places, imaging might be able to show where the organism could be originating from. And the reason source identification is important is because source control is crucial. So removing the source is optimal, and sometimes surgical debridement might be needed. Now, for the empiric treatment of bacteremia, it is important to start treatment early in order to decrease the rate of mortality. And the choices of antibiotics really depend on the source if known, and also on the history of the patient. So for example, if the patient has a history of multi-drug resistant organism, then broader antibiotics are needed empirically. And of course, tools such as gram stain as well as rapid diagnostic tests are available to optimize the empiric therapy as soon as possible. Now, initially, empiric treatment should be intravenous because the infection is in the blood, and IV antibiotics give the antibiotic 100% into the site of infection. Now, there are some antibiotics that do not achieve enough concentration in the blood and should be avoided, regardless of whether oral or IV. So nitrofurantoin does not achieve enough concentration. It goes straight into the urine. Colistin, which is an IV antibiotic, does not achieve enough concentration in the blood, goes straight into the urine, as well as tetracyclines. So tetracyclines, especially tigecycline, have very large volume of distribution. So they basically achieve high concentrations in most tissue in the body, but very little stays in the blood. So they are not ideal for bacteremia. In fact, there is a black box warning for tigecycline for increased risk of mortality as a result. And rapid diagnostic tests, such as multiplex PCR, are able to identify or select organisms as well as resistance early on. So within 24 hours of infection, these results can be available, which are often used in the sense that if one of these genes show up, then if the empiric treatment is not covering that specific resistant organism, then the treatment can be escalated. We described the common mechanisms of bacterial resistance and explained the mechanism of action of beta-lactams. Given a patient case, we recommended effective drug therapy for the treatment of bacteremia. Now, let's change empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. When susceptibility results become available, therapy must be changed to a more narrow spectrum agent based on those results. Now, occasionally, escalation is needed if the organism is resistant to what we were using as empiric therapy. Now, while initially IV antibiotics are required for treatment of bacteremia, oral antibiotics can be considered, especially those with good bioavailability more than 90%, and preferably the ones that have clinical data to support use. Most clinical experience with oral antibiotics is for gram-negative bacteremias. With gram-positive bacteria, because of a more serious complications such as endocarditis and difficulty to eradicate due to formation of biofilm of gram-positive organisms, especially with Staphylococcus and Enterococcus species, IV antibiotics have historically been recommended for the entire duration of therapy. However, recent clinical trials such as the POET trial that included patients with endocarditis suggest that oral antibiotics may be used for gram-positive bacteremia as well. Now let's take a look at pathogen-directed therapy for bacteremia. First, let's consider methicillin-susceptible Staphylococcus aureus or MSSA. So for MSSA, treatment of choice is either an anti-staphylococcal penicillin such as nafcillin or oxacillin or cefazolin. And these are considered first choice. They are all superior to vancomycin for definitive treatment of MSSA bacteremia because they have mortality benefit. So, if patients receive vancomycin for pathogen-directed MSSA bacteremia, they're more likely to die compared to receiving these. Now, cefazolin is first-generation cephalosporin, and compared to nafcillin and oxacillin, cefazolin is a much safer option. So both nafcillin and oxacillin are nephrotoxic. So, patients are more likely to develop nephrotoxicity compared to receiving cefazolin. In addition, nafcillin and oxacillin are more likely to be hepatotoxic, so they are more likely to result in increased AST and ALT, so transaminases. And when you look at the dosing, I haven't listed the dosing for these agents here. Cefazolin is dosed every 8 hours, whereas nafcillin and oxacillin are actually dosed more frequently, every 4 hours. So it makes it more difficult to administer. Cefazolin, much better option. Now, of course, if somebody cannot tolerate beta-lactams, then vancomycin would be an alternative option for them. For MRSA bacteremia, drug of choice is vancomycin or daptomycin. Vancomycin is historically more affordable than daptomycin, so people most often use vancomycin. Now, that is based on, directed cost of acquisition when you compare vancomycin to daptomycin. Now, if you consider that vancomycin requires therapeutic drug monitoring, so you essentially need to pay a pharmacist to basically get vancomycin levels and make adjustment. One could argue that daptomycin might be more cost effective. But regardless, either vancomycin or daptomycin would be treatment of choice for MRSA. And the reason linezolid is not considered drug of choice is because typically with MRSA, we need to treat for at least 2 weeks. And linezolid becomes problematic when you treat for long periods because of adverse effects. So vancomycin and daptomycin are much better tolerated, and they're considered drugs of choice. Now, however, everything we have listed so far is only available as IV. One advantage of linezolid is that it is available as PO. So it would make it easier when transitioning from IV to PO. Now, in general, with MRSA, for the most part, we treat the entire duration as IV. In the POET trial, no patient had MRSA. So although, there is some evidence for oral treatment of gram-positive bacteremia, none of those patients had MRSA. So, pretty much standard of care right now for MRSA, for the most part, is IV treatment. Now, for VRE, which is vancomycin-resistant enterococcus, vancomycin, of course, is no longer an option because this is resistant to it. So now you have daptomycin or linezolid. And, with VRE, you don't need to treat as, for very long times as we do for MRSA. So typically shorter duration of treatment. Linezolid becomes an option. And when you compare daptomycin to linezolid, daptomycin might have an advantage because, for one, linezolid is bacteriostatic, but daptomycin is bactericidal, so has more potent activity. But also, daptomycin is easier because it's in normal renal function, it's administered once a day, whereas linezolid is typically twice a day. But on the other hand, again, linezolid has an oral option, whereas daptomycin doesn't. So, there are pros and cons, but regardless, both of them are considered treatment of choice for VRE bacteremia. And so these were gram-positives. When it comes to gram-negatives, one thing that's very important is treatment of ESBL bacteremia. And carbapenems are considered first-line treatment for ESBL bacteremia. In fact, meropenem was shown to be superior to piperacillin tazobactam in randomized controlled trial. So people were less likely to die if they were receiving meropenem compared to piperacillin tazobactam. So there's mortality benefit with carbapenem. So now they are considered first line for ESBL bacteremia. And cefepime should be avoided because of increased risk of mortality. And this is, regardless of susceptibility. So if the patient has blood cultures growing, let's say ESBL producing E. coli, and is susceptible to piptazo and cefepime, as well as meropenem, we should avoid using cefepime even though it is susceptible, and we should avoid using piperacillin tazobactam, and we should use carbapenem because of the mortality benefit. And lastly, other gram-negative organisms, considering they are not multi-drug resistant, because there are other resistant scenarios that are beyond the scope of this lecture. So we will not cover carbapenem-resistant Enterobacterialis, I will refer you to IDSA guidelines for treatment of those infections. Multi-drug resistant Pseudomonas, Cinetobacter, and other multi-drug resistant organisms we will not cover in this lecture. So other gram-negative organisms that are pretty much easy to treat, things like a normal E. coli that's not resistant to multiple drugs, or even Pseudomonas that's not resistant to multiple drugs. So essentially wild-type gram-negative organisms. You essentially choose the narrowest agents based on susceptibility results and PK/PD properties, meaning you want to choose agents that have good concentrations in the blood. For example, you want to avoid tetracyclines in general, because tetracyclines have a high volume of distribution, meaning that they distribute throughout tissue, so very little concentration remains in the blood. So if your treatment, if the site of infection is in the blood, you actually want the drug to stay in the blood and not go to other tissues. And things like, doxycycline, tigecycline, these are antibiotics that do not achieve high concentrations in the blood and should be avoided. Now, for oral treatment of gram-negative bacteremia, there are certainly more data when it comes to oral IV to PO switch for gram-negatives. And in general, we want to use high bioavailability drugs such as fluoroquinolones and trimsulfa. So you can see trimsulfa and fluoroquinolones have high bioavailability. Now that's preferred. Occasionally, if the patient cannot get these, then and only then oral beta-lactams may be considered. But you do have to make sure that you give a high dose to make sure you get enough concentration in the blood. So these are pretty high dose. If you are to use amoxicillin, you want 1 gram every 8 hours, or if amoxicillin clavulanate, it's at least 875 milligram, ideally 1 gram PO every 8 hours. If it's cephalexin, 1 gram PO every 6 hours. Now these three are preferred if you are to use an oral beta-lactam, and there are less data for the other oral. So if it's best to avoid the other ones due to lack of enough studies showing that you could get enough concentration with cefdenier, cefodoxime, and cefadroxil. But if you cannot achieve, if the patient cannot get these other, you could potentially use this, but you have to make sure that you use higher doses than normally we use. So you want to optimize the dose. We described the common mechanisms of bacterial resistance and mechanism of action of beta-lactams. We recommended effective drug therapy for the treatment of bacteremia, and we changed empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. Now, let's select total duration of therapy for bacteremia based on causative organism. Here are some general principles for management of bacteremia. So it is important to repeat blood cultures every 1 to 2 days, so every 24 to 48 hours after a positive blood cultures until there is a negative culture. And in general, the very first blood culture that's available, that will be considered day 1 of therapy. And that is because that's when we confirm that the source of infection has been controlled. Because for many of these bacteremia where the source of infection is not controlled, blood cultures continue to be positive for many days. So as long as the source of infection is not controlled, any antibiotics that has been used has not really been able to eradicate the infection. Now, for uncomplicated gram-negative bacteremia, a total of 7 days is appropriate. Specifically in patients who have achieved source control, are afebrile for at least 48 hours, and are hemodynamically stable. Especially if the source of bacteremia is from the urine caused by Enterobacterales. Otherwise, a longer duration of therapy of 14 days may be needed based on clinical judgment, especially for non-fermenting gram-negative organisms such as Pseudomonas and Acinetobacter. Now, it's important to note that there are no clinical practice guidelines for gram-negative bacteremia. So you may see that at different places, practice might be different. For MRSA specifically, there is an IDSA guideline that was published in 2011, and it recommends that for adults with uncomplicated MRSA, vancomycin or daptomycin for at least 2 weeks is recommended. And the definition of uncomplicated MRSA bacteremia is someone who does not have endocarditis, there are no implanted prostheses, so no hardware, follow-up blood culture performed on specimen obtained 2 to 4 days after the initial set that do not grow MRSA, so there should be a negative culture within 2 to 4 days, and defervescence within 72 hours of initiating effective therapy. And defervescence basically means resolution of fever within 72 hours. And there should be no evidence of metastatic site of infection. In other words, the infection should not be going from the blood to other organs or any other site. If the patient meets all of these criteria, the bacteremia will be considered uncomplicated. Otherwise, if the answer to any of these is yes, then the patient has complicated MRSA bacteremia, and then the duration of treatment is 4 to 6 weeks, so at least 4 weeks. And then the way, whether it should be 4 weeks, 5 weeks, or 6 weeks depends on how the patient responds during the first 4 weeks and based on the clinical judgment of the clinicians. This concludes this presentation.